Good afternoon, everyone. My name is Dr. Raquel Romero, and I'm going to be the facilitator for the ECHO session today. Thank you for making the time and joining us our session today. I would like to start by providing a brief overview of the comprehensive lung care for underserved communities. This is an innovative delivery and dissemination model project, also known as a Comunidad. At the UT Health San Antonio, our post-COVID-19 recovery clinic serve both San Antonio and also a really large rural region in South Texas with a predominantly Hispanic population. This community faces significant health disparities and barriers to care and misinformation about long COVID and remains widespread. To address those challenges, the Comunidad Project, this is a 5 years initiative funded by the Agency for Healthcare Research and Quality and the Comunidad Long COVID. ECHO seeks to improve and expand long COVID care through innovative and sustainable models through our region and beyond. For those that are new for ECHO, ECHO stands for Extension for Community Healthcare Outcomes, and it serves as a virtual telementoring specifically designed to create a connections between communities and subject matter experts. At this session, you will see an introduction, and then we have didactics, and then we have a case presentation. And then we invite everyone to join us in the case discussion. Because we present in a real life cases, we ask, please don't talk and don't discuss any personal health information because it's not allowed in the presentation of these cases. And we invite you to think in the future if you would like to present a case in our sessions. If you have that, please contact the ECHO team for that. I would like to ask you for our attendance records. Will you please enter your name and affiliation in the chat? This is for our attendance records. You can also use the chat for any question, comments, suggestions through the session. And we invite you to be part of the discussion, particularly in the case discussion. And if you can join us by video, if you're feeling comfortable, please join us by video. We would like to see all your faces. Now I would like to move to the introductions for our team, and I would like to start with Dr. Tegrarian, who is going to present the case today. Would you please introduce yourself?
Hello, everybody. My name is Roy Tagarian. I'm a psychologist here with the Long COVID Clinic, and I treat patients that are suffering from psychological distress related to long COVID.
Thank you very much. As presenting the case for today, we have as a part of our hub team, we have Dr. Sabat, who is the lead specialist for today.
Hi, everyone. Joel Sabat, general internist and health services researcher, community engaged researcher, direct the Reach Center, and I'm happy to have everyone on this long COVID echo.
Thank you very much. We have also, as a part of the HIM, Dr. Kepela.
Hi, everyone. Lisa Smith-Coppola, Associate Professor of Medicine, one of the principal investigators on this grant. Like Roy, also a clinical psychologist. And so good to have you all. Thank you very much. And if you have any connection through the session or any problem with the connection, please contact our IT. We have a Kato and Maria that can help us with our connection. Thank you so much. And we have also part of our team today, Dr. Nambiar is presenting the didactics for today, and that was recorded. So, Kato, on your time.
Hello, everybody. Thank you very much for inviting me to talk today. Good morning, good afternoon, good evening, I guess it depends on where you're at. But thank you very much. Hope everyone's doing well and greatly appreciate this opportunity to talk about the pulmonary manifestations of long COVID. And I know this is something that everyone on this call, I'm sure, has seen many patients with long COVID. And as we all know, it's a very debilitating disease process for a lot of our patients who survive acute COVID, and something that I think we all want to learn about, how best to take care of our patients to really help them improve their quality of life and hopefully survival. So I'm Dr. Anup Nambiar. I'm a professor of medicine here at the UT Health San Antonio and the University Hospital in South Texas. I'm the founding director for our Center of Interstitial Lung Diseases, and also am the founding director of the pulmonary component of our VA, South Texas VA post-COVID program. So just to give you some idea, I've taken care of probably over a few hundred post-COVID patients and reviewed multiple CT scans and PFTs on many of those folks. So disclosures, these are my disclosures with various industry groups and companies, majority of which I participate in research studies and receive grants, and some of which as a speaker and consultant. But as I'll mention this next one, none of those relationships are relevant to this discussion, and won't be discussing really any specific treatments. Unconscious bias disclosure, UTL San Antonio Echo recognizes the language is constantly evolving. While we make every effort to avoid bias and stigmatizing terms, we acknowledge unintentional lapses may occur in our presentations. I'll do my best not to have that. We value your feedback, encourage you to share any concerns related to language, images, or concepts that may be offensive or stigmatizing. Your input will help us refine and improve our presentations, ensuring they remain inclusive and respectful to our participants. So learning objectives for this talk, and I'm aiming for hopefully 20 minutes, is number one, describe the spectrum of pulmonary long COVID manifestations. Number two, gain awareness of the diagnostic evaluation in a long COVID patient with respiratory symptoms. And number three, understand the currently available and near future therapies for pulmonary long COVID. So just as an opening, and I know many of you are well aware of this, but just the kind of the timeline of COVID in general, when starting with acute COVID over here, which as we all know, symptomatology starting pretty early on after a few days. And we know we have treatments available that usually are most effective in the first few days, 5 days or so with Paxlovid. And ultimately, though, some patients can persist and progress even towards severe disease, hospitalization, or critical illness requiring intensive care unit, intubation, mechanical ventilation. But what we're focusing on in terms of long COVID or post-acute COVID are those persistent symptoms and disease processes that can occur really in multi-organs. So it's a heterogeneous processes. A lot of patients with fatigue, quality of life changes, muscular weakness, joint pain, changes in the brain, psychologic function, cardiac disease, kidney disease, even hair loss. But we're going to be focusing on, for this talk, really on those persistent, debilitating symptoms of shortness of breath or dyspnea, cough, persistent oxygen requirement, and usually we're talking about at least over 3 months or longer with these persisting. So long COVID, all different names, as you all know. We, at some point early on, we used to call this PASC, post-acute sequelae of acute COVID-19. Things have changed. I think actually long COVID has been derived from many of the patients, COVID survivors, who have been reporting these persistent debilitating symptoms and have used the term long COVID. And we know that about 1 in 5 adults over 18 have a health condition that might be related to their previous acute COVID illness. And as I mentioned, a very heterogeneous, multi-organ dysfunction type of process. And like I said, we're going to be talking mostly about respiratory conditions and specifically with the lungs. And the CDC announced approval of the ICD-10 code, as I'm sure you all know about this, that we oftentimes use when we do see these patients in our clinic with post-COVID conditions. So the most serious pulmonary long COVID conditions and processes we've identified, really number one, I would say, is post-COVID ILD or interstitial lung disease. And as I mentioned earlier, I'm the founding director of our ILD program, which is actually one of 81 centers of excellence recognized by the Pulmonary Fibrosis Foundation in the entire United States. one of 5 in the state of Texas, and right now the only one in Central and South Texas as a center of excellence. So this is something that, as a regional referral center, we get many patients with ILD after having COVID. And we'll talk more about the details on that. Post-ARDS, pulmonary fibrosis. So a lot of patients, as an ICU doc, I see in the intensive care unit, intubated, on a ventilator, and having a picture that is identical to ARDS, because we know infections are a common cause for ARDS, acute respiratory dysfunction syndrome. These folks are very sick in the ICU, oftentimes maybe not only needing the ventilator, but maybe even needing ECMO, extracorporeal membrane oxygenation, to help them with their oxygen levels. And unfortunately, many of these people do not survive. And if they do survive, then we can see many of those survivors having sequelae with fibrotic lung disease and other manifestations. And number 3, thromboembolic disease. So we know that there's an increased risk of blood clots, so pulmonary emboli in these patients acutely, especially the more sick they are, critically ill. And what we don't know is the long-term sequelae, but oftentimes we treat them with anticoagulation, and then we monitor them long-term, and that's something that data is still emerging as far as long-term outcomes for those folks. So just to kind of touch base a little bit on the pathogenesis of post-acute COVID-19 pulmonary fibrosis. So basically, we know that there's a number of different virally activated pathways. So the process is initiated by that infection. And ultimately, that leads to various multiple different pathways getting toward inflammation and fibrosis. You get cellular injury, an inflammatory milieu, mechanical injury, especially if they're on the ventilator, all of which can then add to additional significant inflammation in the lungs, which there's really then a fork in the road. Either those folks then improve and recover after viral clearance, wound healing, and ultimately resolution. I'll show you some CT scans on some patients where there is complete resolution of the acute injury, or in some people, and we'll talk about risk factors, some people then can develop fibrosis. So a way to think about this is that inflammation is potentially reversible if we identify it early and treat it aggressively early on, versus scarring or fibrosis in the lungs, which is generally regarded to be irreversible and chronic, and I think very importantly, can be progressive in some patients. And we'll talk more about that in a bit. So long COVID risk factors really have been identified as being severity of the acute infection. And I think this is something that, especially with pulmonary sequelae, has been identified that the sicker somebody is acutely with their COVID, the higher the chance that they're going to have sequelae in the lungs and complications, and with chronic pulmonary disease. So severely critically ill patients are the ones at the highest risk, but we also think hospitalized and intensive care unit patients are also, even if they're not intubated, can still be at high risk. Now, I wouldn't completely, as we know in medicine, there's almost, you can never say never. So I would say that even folks who are more mildly ill, non-hospitalized, there could still be some risk, but I think the data, at least so far, shows there's a significantly higher risk if you're hospitalized and critically ill, having long COVID with the lungs. Vaccination status also has been identified, so those are unvaccinated or much higher risk than vaccinated. And COVID variants also appear to be influencing whether or not somebody develops long COVID in the lungs or not. Earlier variants appear to be higher risk compared to later on variants. And whether or not it's the actual virus variant itself or the vaccination on top of that, I think to be determined, and may not be able to be cleanly differentiated, but it looks like later variants, probably because of also combination with the patients being more vaccinated, has helped kind of reduce that risk of developing pulmonary long COVID. Also identified older age, comorbidities, higher BMI, as being risk factors too for developing long COVID in the lungs. So symptoms from pulmonary standpoint and signs, I think this is something that we all see a lot. Patients survive acute COVID, but still having shortness of breath or dyspnea. So at least some data shows that pretty high chance of that, especially those who've been hospitalized, 81% at 3 months. Then it gradually seems to be reducing 25%. However, up to 23% or up to 30% even can be having prolonged persistent shortness of breath after a year. So that is something that I know we do see that a lot in our patients. Cough can also be pretty common, up to 21%, up to 6 months after acute COVID. Decreased exercise capacity. I think we hear this from our patients a lot, that the walking, based on a 6-minute walking distance. So that's our test that we use in the clinic, where we have somebody walk in the hallway and we're aiming really for a 6-minute period and telling the patient, try to walk as far as you can in 6 minutes, not necessarily as fast as you can. And we see when we look at the walking distance in that 6-minute, we can see that it's abnormal in up to a quarter patients at 6 months and 12 months after COVID. And then persistent hypoxemia, even up to 60 days follow-up. Thankfully, this is a relatively small number, but I think you can make an argument still significant at 6.6% needing oxygen even up to 2 months after their acute COVID. And that would be a concern that there's some serious ongoing cardiopulmonary issue that could be driving that needs to be further evaluated, investigated, and treated. So as far as PFT, pulmonary function abnormalities. So PFTs are something that we do regularly at our pulmonary clinic, really to assess anyone with any respiratory symptoms, shortness of breath, cough. And what we're looking for really is a few metrics. Number one is how big or small someone's lungs are. And that we can base on something called the FVC, the forced vital capacity, but also a DLCO. So this is the diffusion capacity that basically when somebody's taking a deep breath in and holding it, measuring basically how is oxygen going through their lungs. And what has been shown in patients with pulmonary long COVID is that there's a pretty significant number of patients that have a reduced diffusion capacity. And this is the most commonly identified PFT abnormality in post-COVID patients. So up to 60% of patients at 6 months have a reduced diffusion capacity, up to 50% even at 12 months, so persisting. And like I mentioned before, big risk factor is correlating with severity of acute illness. And this has been consistent with prior studies also looking at survivors of ARDS and other different kinds of viral infections. And so usually when I see a reduced diffusion capacity, it still could be due to a number of different things, but most concerning would be some kind of fibrosis, as pulmonary fibrosis or lung scarring can reduce that diffusion capacity. And oftentimes it correlates pretty well with the DLCO as far as the extent and severity of the fibrotic change. And then the other thing I mentioned, restrictive ventilatory pattern. So when the lungs are, if there is significant fibrosis, the lungs shrink, they get smaller. So somebody cannot get as much air in and out of their lungs. And we can assess that based on a forced vital capacity or FVC and a TLC, total lung capacity. So these are breathing test parameters, and identified that 1/4 of patients hospitalized for COVID-19 after surviving at 3 months and 6 months have a reduced FVC, and even more, even up to 40% of critically ill patients and up to 30% even at 12 months. And this all appears to be fairly similar to historical ARDS survivor populations who have developed sequelae such as fibrosis in lungs after such a severe critically ill acute infection. As far as chest radiologic abnormalities, so when there's been studies and if a patient has symptoms and they have abnormal PFTs, especially a reduced diffusion capacity, the only way to rule out or rule in the presence of fibrosis in lungs would be a high resolution CT, or HRCT for short, of the chest. And when this has been done, most common abnormality is something called ground glass opacities. So, or GGO, these are kind of areas of hazy white that you can see in the lung. You can still see blood vessels through that area. So we would not call that consolidation or area of complete white, but we'd say hazy white, that would be ground glass. And that is a non-specific radiologic term. Basically can be due to anywhere from infection, which can even be acute or chronic. It can be inflammation in the lung, which can be acute or chronic. And it can even be fibrosis. It can be fluid. So it could be a lot of different things going on in the lung that cause ground glass. But it was found that in patients surviving acute COVID at 6 months, up to 90% had this ground glass opacities, 70% at 12 months. And fibrotic changes can be even present also up to 65% at 3 months. But again, a lot of times it's those with more severe acute injury and other risk factors that can develop fibrosis of the lungs. And also depending on severity in terms of their oxygen requirement, then we can see whether there's a spectrum of mild to moderate to even more severe, especially if they're needing more oxygen. And as far as thromboembolism or PE, pulmonary emboli, or and DVT, we know there's a higher risk for that in acute setting. But as far as afterward, like in terms of chronic PE and pulmonary hypertension, really has not really been identified as being something of something we're looking for or aware of, but really studies haven't really not borne out. It looks like a lot of the patients after getting treated with anticoagulation in the early on phases, then we can usually take them off, usually at 3 to 6 months. And but that is something that I think those patients, we just need to get more data on long-term outcomes. So I thought this is a pretty cool article in New York Times looking at COVID's lasting damage to the lungs. So in case anyone's interested, I think it's worth taking a look at. And they did these really cool 3D reconstruction of lung scans, CT scans, that show the damage that can be done that lingers on, exactly what we're talking about, especially for those severely ill. And you can see at 6 weeks with these areas of white representing the inflammatory process, so significant amount of lung inflammation. And then over time, 3.5 months, and even 6 months, where basically then you get into the inflammation then transforms itself to more fibrosis, and that is irreversible. And like I said, we've seen many patients, especially in the earlier phases, before vaccination, critically ill. Many of these folks have been, unfortunately, have pretty significantly damaged lungs that causing a lot of symptoms and impaired quality of life and survival. So I wanted to show you some CT scans. Like I mentioned at the VA, I'm directing the pulmonary component of the post-COVID clinic there. And so we've looked at many CT scans on patients acutely and then over time. And so I'll show you the scan of acute, severe acute COVID-19 pneumonia. What we're seeing here basically is a slice. So a CT scan is just X-ray slices at the carinal level. So the split between the right main stem and the left main stem. And what you see is the lung should be mostly black, and you can see a lot of white. So a lot of white, when we call this changes, if you can see the blood vessels through those areas of white, is ground glass opacities, as I mentioned before. So bilateral, significant ground glass opacities. And when we get to the lower part of the lungs, here in the bases, and you can see the right base here and the left base, basically pretty significant amount of consolidation. So areas of white on the X-ray but you can't see through it. And that would be much more severe kind of either inflammation, scarring going on in the lung. But then you can see that over time, just 2 months later, this person had significantly improved. So, and this was early on in the pandemic. So in June 2020 to September 2020, we really did not know or have any safe, effective treatments. And you can see that significant improvement there, and probably some component of when dexamethasone came out, as we know, can be a good treatment, especially for hospitalized patients or severely critically ill patients. That probably helped in addition to just time improving this radiographic abnormalities. And however, you can still see some residual changes. So not completely resolved, but I would say pretty significantly improved, and even upwards of probably close to 90% improvement. And as far as another case, 76-year-old male with severe acute COVID, now you can identify these opacities, areas of white bilaterally, consolidative mostly. So when we see that again, we're pretty concerned that there's a lot of inflammation and fibrosis maybe developing. And this is at just below the carinal level. This is in the lower part of lungs, by both sides of the lung affected. And you can see pretty significant improvement. However, like I mentioned, one of the big risk factors for developing long-term radiologic abnormalities is going to be the acute injury and severity. And this person had pretty severe abnormalities to start with. And so there was improvement, but you can see more residual abnormalities than the prior patient had, but there was improvement. It's hard to say there was not. And the next one, again, bilateral ground glass, significant, not as dense as the prior patients having that dense areas of white consolidation, but pretty significant ground glass close to consolidation. And here you can see significant improvement, almost near, pretty much almost complete resolution over time. And this is a time frame about 8 months from after their severe acute COVID. So at least from what we've seen and what the data bears out, is that a significant number of patients do improve clinically, physiologically by PFTs, radiologically, after usually within in the 3 months period afterward, up to 6 months. There looks like there could still be some more improvement after 6 months. I would just say, in my experience, majority of that improvement, it kind of plateaus out usually at 6 months. And now usually whatever changes, residual abnormalities are there at 6 months will persist, and usually representing long-term damage to lungs that is irreversible. As far as pulmonary long COVID screening and diagnosis, so obviously we know that there's a major research priority by the NIH, professional organizations looking at this. And I know part of this program that we're doing, and also around the country, all involved in collaborating and trying to, again, develop better, safer mechanisms of helping patients with long COVID improve the quality of life and survival. However, really no widespread consensus guidance recommendations that I've seen in pulmonary long COVID, at least. And we talked about ILD, interstitial lung disease, inflammation, fibrosis in lungs. We mentioned thromboembolic disease, also something of note that we have to keep an eye on. And who should be screened, whether is it all patients or those with symptoms. I think just from it would be ideal, and as a researcher myself, to look at everybody after COVID. And that's something we did at our VA post-COVID program. Regardless of symptoms, we looked at folks afterward, but then we realized that from a resource standpoint, it's really just not realistic to screen everybody after COVID for who does not have symptoms. So we started more on those with symptoms like shortness of breath and cough. And that's kind of where then you can identify potentially some abnormalities or not. So remember, shortness of breath is non-specific. Patients can be short of breath for a number of different things other than the lungs. They can be short of breath because of a cardiac issue, which actually should be thought about pretty early on, especially if there's risk factors for cardiac disease. Should be looked at for anemia, electrolyte abnormalities, and then ultimately even physical deconditioning, as we know, can be a pretty significant issue with these patients. And I mentioned anyone with symptoms should get testing for the lungs. And usually what I would start with is pulmonary function testing, PFTs. Mentioned already that the frequency of abnormalities on PFTs can be significant. 6-minute walk test should be done primarily not just to look at walk distance, but also assessing for the need for oxygen, supplemental oxygen at rest or with exertion. The guidelines we'd say is that if anyone desaturates to 88 to 90% or less, then they would qualify and should benefit from supplemental oxygen during those activities, whether it's at rest, exertion, or while sleeping. And I try to tell patients every day in clinic how to separate those. Those are 3 different phases. And typically oxygen levels are the best at rest and should go up with activity when there's a normal heart and lungs functioning. If there's lung disease or heart disease, typically oxygen levels drop with activity, and sleep will be somewhere in between. That needs to be assessed separately. And then ultimately, I usually start with an X-ray, a plain chest X-ray, just to pick up any big abnormalities. But if any abnormalities on the PFT, walk test, or X-ray, then I think a CT scan of the chest should be done to look for kind of any more potentially significant, serious sequelae like fibrosis. So when and how often? So as I mentioned before, this is something that early on we were looking at pretty closely. And I think as we learn more about the natural history of post-COVID in the lungs, then we kind of maybe can individualize and tailor this. So I would say at least at baseline, take a look at things. If any abnormalities identified, then I would say we probably need to keep an eye on things. Depending on really symptoms, severity of symptoms somebody has, I would kind of decide on whether should we see them back in 3 months, 6 months, just to get a couple of data points. And if they remain stable, then I think we could even extend that to 6 to 12 months. But always telling the patient, if you have anything new or different going on, let us know so we can bring in earlier and get things reevaluated. So as far as treatment goes, unfortunately, really, there's no specific long COVID pulmonary treatment that's been proven to be safe or effective. Many studies have been looking at different drugs here and there, but really nothing that has been, like I said, approved for the use of patients after COVID from the lungs. Smoking cessation, if they're actively smoking, is a general good rule of thumb for anyone with any lung issues. Home oxygen, as I mentioned, if qualifying based on a 6-minute walk test, or even overnight oximetry test at home while they sleep, or a sleep study. Because sometimes, even despite treating for sleep apnea, if somebody still has low oxygen levels, then supplement oxygen may be indicated at that point. I think pulmonary rehab, I don't think try to convince anyone on this call the importance of pulmonary rehab. Anyone with lung disease, chronic lung disease, especially ILD, COPD, we know gets a significant amount of benefit from a supervised exercise program and educational component of that program. And that's one of the things that I think patients really enjoy when they participate in that. Systemic steroids. So corticosteroids have been looked at, as I mentioned, acutely. There is really solid data, and that's why we use it for hospitalized patients with severe COVID or critically ill patients. After acute COVID, there are some studies that suggest that some patients may benefit after acute COVID in a subacute phase when there's more of we call it an organizing pneumonia, which is mostly an inflammatory, not infectious inflammation of the lungs. And there are some studies that maybe suggest those folks having ongoing residual significant inflammation of the lungs could benefit from some steroids in the subacute phase. But general rule of thumb that we use is basically after really 6 months, damage is done, unlikely any active ongoing inflammation that's worth treating with steroids and taking on pretty significant side effects. And at that point, we just monitor. I would not recommend steroids usually after 6 months because at that point it's mostly fibrotic, irreversible, and not responsive to steroids. We do have antifibrotic drugs. So we have medicines that have been shown to slow down worsening scarring. These are primarily indicated for patients with ILD, such as idiopathic pulmonary fibrosis, a very specific progressive type of lung disease, and also any patient with any progressive fibrosis, most oftentimes due to autoimmune diseases or hypersensitivity pneumonitis. In my experience, I have not really seen any patients with progressive pulmonary fibrosis after acute COVID. It looks like once the injury has occurred and fibrosis has set in, it typically does not progress. However, if there is a progressive fibrosis in somebody who survived severe acute COVID, I'd actually consider looking at alternative reasons for that, such as an autoimmune disease, such as an exposure that could be driving the progression as opposed to it itself being from the acute COVID injury. And then ultimately lung transplantation. So I think this is something that in any patient with a severe, progressive, chronic irreversible disease like pulmonary fibrosis, which is the #1 reason people get lung transplanted, then it should be thought about, it should be considered. However, in a patient with long COVID and fibrosis, oftentimes we may not transplant them because the natural history appears to be that they stay stable and do not progress. But in somebody with a significantly impaired quality of life, especially oxygen requiring, I would suggest referring them to a lung transplant team. So we still have many unanswered questions for post-COVID ILDs, how common, risk factors, but I think we have identified some of the risk factors I mentioned earlier, natural history, vaccination effect. So it looks like these are all, overall, patients are doing better. There's less prevalent severe fibrosis in lungs post-COVID, likely because vaccinations and the variants maybe not being as dangerous. Which patients should be screened and monitored? As I mentioned, I think anyone with symptoms should be looked at and screened and monitored. And in my own practice, even if I do have a patient with post-COVID ILD fibrosis in lungs, basically I usually say as long as things are stable, then we just monitor every 6 to 12 months in the clinic, usually with at least PFTs. And then we decide about whether we need to get CT scans, at what time frame, but usually I'd say consider every year, year and a half, or less frequent, especially in our younger, maybe female patients, or those are more vulnerable to imaging related type of issues like cancers. Optimal treatments, again, still remain unanswered. Really no high quality, prospective, well-controlled studies. So placebo-controlled, a lot of the studies I've seen kind of do not have that. And so we don't know, without a control group, we won't be able to tell whether or not any of the specific therapies we can offer have a benefit compared to not treating. And in my opinion, in my experience, a lot of the patients do not need specific treatment. And if we do studies, we need to have the placebo group for a good, well-designed prospective study. And again, when and whom lung transplant should be offered, again, anyone who's sick, severe, on oxygen because of a chronic lung disease, lung issue, they should be referred to a transplant team for evaluation. So to finalize, key points, I mentioned symptomatic, such as dyspnea, reduced exercise capacity, things like that. Physiologic abnormalities, DLCO, FVC, radiologic abnormalities, ground glass, fibrosis, are very common in post-COVID-19. True clinical significance of pulmonary long COVID, though on important patient outcomes, remains unknown. It's also unclear which pulmonary long COVID patient should be tested, what testing should be done, when should be done, how frequently. And this is something I think over time it's evolved and it will continue to evolve as we get more data. I would just kind of emphasize it depends on the severity of patient symptoms. And the more severe symptoms, the more closer they need to be monitored. The less severe, the less frequently and closely they need to be monitored. Optimal treatment depends on accurate diagnosis, severity, trajectory. And with pulmonary long COVID, therapy should include always smoking cessation. In selected patients, we also need to consider home oxygen if they qualify, pulmonary rehab, systemic steroids, antifibrotics, and lung transplant.
Well, it was a very good presentation from Dr. Anambiar, and because it was recorded, we wanna have his email address perhaps in the chat, or if you have any question further, we can always send them to him because he's not present right now. But I know it was a very, very good presentation, very detailed information. So because of that, we wanna move to our case presentation. Dr. Degrarian has the case for today. Now just base. And you are muted, Dr. Degrarian. Thank you.
Of course, I was muted. Hello, everybody. Hey, so just a couple of things before we get started in the actual case presentation. And many of you know this already, but I think it's a good baseline setting for us to make sure that we're anchored to what we're doing here. So long COVID involves, biological, physiological, and physical changes in the body. And as a result, it can impact one's psychological well-being, and that can cause psychological distress and suffering. So as part of UT's long COVID clinic, we offer psychological services, and they're offered because people living with long COVID, it can be isolating for them. It could be stressful, and it could be emotionally exhausting. It's really important to acknowledge up front that many people that have suffered from long COVID and are suffering from long COVID have had their experiences not being believed or having their symptoms minimized. One of the important things here is that the psychological services that we offer here is not to explain away a patient's symptoms as psychosomatic. They're offered to support individuals experiencing distress related to living with long COVID. So I thought that was important to level set, because this case presentation is going to take a little different approach. It's going to be psychological in nature. It's going to be less physiological, biological, and physical. That's the domain of the physicians, and I'll leave that in the good hands of them. What we're going to focus on here is the psychological impact of somebody suffering from long COVID. So this is a 45-year-old female. She received her first, she contracted COVID twice. The first time was in December, January of 2020, and then again in January of 2021. It was after her first infection that she began to experience symptoms of long COVID. So the patient has essentially been living with long COVID for approximately 6 years. Her marital status is divorced. These key details matter as we get into the psychological distress that she's experiencing. She has 2 children, ages 7 and 14, and when she contracted COVID, which subsequently turned into long COVID, her kids were 2 and 9 years old. She shares custody with her ex-husband. They have 50-50 custody. She's employed full-time in a sales role where she's able to work from home. There's a family history of hypertension and ADHD. She's got some pretty extensive social support. She's got a supportive family and friends, which include her mother, father, her 2 sisters, and about a half dozen close friends that she's in contact with pretty regularly. From a financial perspective, the patient is experiencing moderate to severe financial distress, and this is primarily related to maintaining a home since her divorce and the impairment from long COVID. Now, it's important to note that the divorce actually occurred because of her long COVID. Her ex-husband, the way the patient describes it, abandoned her in her time of need. So she was emotionally abandoned, and as a result is now suffering some financial distress trying to maintain the family home. So she physically just cannot be able to maintain the home with the demands of home ownership. And as a result, the patient is considering selling the home and moving in with family due to the required physical and financial upkeep of maintaining a home. So her family home, the home that her kids call their childhood home, has now become a burden to her. So she's torn between wanting to stay in the family home and keep things stable for her children, or uproot everybody and move them in with their sister. Patient denies any past or current substance use. There's a history of attention deficit hyperactivity disorder with the patient, anxiety and depression. The patient reports experiencing anxiety her whole life, and then first noticing her depression upon her high school graduation. However, these both have been exacerbated since long COVID. So the patient reports moderate to severe episodic anxiety and depression, given the symptoms of her long COVID. So when she's having more difficult days, the anxiety and depression episodes are more on the severe end, and when she's having better days, they're more on the moderate end. It's important to note, though, that like a noise machine in the background, they're always there. It's always humming in the background for her. Current mental health diagnosis, as I mentioned earlier, ADHD, a moderate to recurrent major depressive disorder, and the patient denies any current suicidal ideation, homicidal ideation, or self-injurious behavior. She was able to identify reasons to live, which were her kids. For psychotropic medication, she's taking Cymbalta, and she's also to address the depression, and then she's also taking Adderall for the ADHD. So she's got a series of physical diagnoses, including long COVID, autonomic dysfunction, POTS, post-viral fatigue syndrome. She also has endometriosis, chronic migraine, and mast cell disorder. And some of the symptoms the patient describes includes headaches, frontal and temple region pounding of the head, brain fog, insomnia, cognitive impairment. She's having trouble with word recall. That's pretty evident in our sessions. She's searching for words. Severe fatigue, post-exertional malaise, shortness of breath, and vertigo. Another important note here is this woman now walks with a cane, and she had a very, very active life prior to long COVID. She was very physically active, exercised regularly, engaged in sporting activities, and now she just can't do those things anymore. Medical treatment adherence. So the patient reports that she's adherent to what her physicians are instructing her to do. However, the fatigue sometimes gets in the way of her being able to fulfill some of those recommendations, but she's doing her best. And then as it relates to the patient narrative, I'm just going to read through these to give you some insight into what happens to individuals who are suffering with long COVID and how it creates psychological distress beyond what we see physically through imaging and what the physicians are treating. So the patient reports feeling sad and angry that she's suffering from long COVID. She's grieving the life she had. She's grieving the life that she thought she was going to have. And she's grieving what the illness has done to her children. So she reports an instance when her 2-year-old, as 2-year-olds want, they want to be picked up, and she just did not have the physical energy to even pick up her 2-year-old child. I mentioned earlier that the patient reports that she was highly physically active, and according to her, she was in great physical shape. And now she's sad and angry about the changes to her body and her physical limitations. Prior to long COVID, she considered herself supermom and led a happy and full life, being a mother, being happily married, working full time, being highly active, high energy, and running a highly organized home, clean and beautiful home. She prided herself on being a supermom prior to long COVID. She reports now that she's not the mom she wants to be, and that saddens and angers her. She wants to be the best mom she can. She wants to be super mom again, and she's really struggling with accepting that she may not be that version of mom that she once was, but she could be a different version of mom. Her husband divorced her 3 years ago due to long COVID and how the illness changed her life. The patient is angry that she was abandoned by her husband and is having to go through this all alone. Patient reports that her ex-husband gets to be the fun dad when the girls are with him, and that causes her to experience sadness and anger at him. Her illness and what it's done to her life and her current life conditions. So there's a lot of anger, there's a lot of frustration, there's a lot of sadness related to this. The patient reports a history of germ awareness behavior, but now she's hyper aware and behaviorally diligent about letting germs into her home. I don't think we're at the extreme end of OCD, but she is exhibiting some OCD tendencies. The patient reports full-time employment in sales, and she works from home in bed. Patient reports her work requires a high cognitive and energy load, and each day at the end of work, she's physically, cognitively, and emotionally empty, and she has little to give to her children after she's done at work. Patient reports that she's never fully rested and often in an irritable mood, and that she's laying in bed and is tired all the time. She also experiences difficulty sleeping due to anxiety. Patient reports distress about selling her children's childhood home, but she can no longer keep it since the divorce, and this really saddens her. Her family is willing to support her, and she's likely going to move in with her sister and her family, but she feels like she's going to be a burden to them. And she sometimes thinks it might be better off to stay in the home and financially struggle than to become a burden to her sister. And finally, patient reports that she suppressed how she's felt for the last 5.5 years. She believes intellectually that seeing a psychologist will be helpful for her, but she's scared about letting it all out and what it might do to her. So those are the psychological components of what individuals with long COVID are suffering from. And she's identified 4 goals for therapy. 1 is to improve her sleep. 2 is to develop coping skills to address her affective distress and emotional reactivity. 3 is to improve her quality of life. And 4 is she wants the space to be a space where she can vent and let out what she's been suppressing for the last 5 years. So that is the patient.
Thank you very much. This is a very, very interesting case, and you presented very good and detailed information about the patient, but also the circumstances, the context that it want to help us to visualize better the situation. I can see that if that's okay to you, we can continue with the discussion in the next session because it is very, very interesting, and perhaps we have a lot of questions, but we have a few more minutes just for any question from the audience as of now, and then I can tell you that if that's okay, Dr. Tegaren, we can continue with this case and then our next session because it's a great learning opportunity for all of us. Any, for interest of the time, is any question, you can say it or you can put it in the chat. But stay in tune because next month we're gonna continue with this case. Dr. Sabat, any thought, any ideas, a lead specialist that you are for our session today?
Yeah, thanks for that case presentation, Dr. Tigrarian and to Dr. Nambiar. I think we heard about 2 very debilitating aspects of long COVID, one primarily physical, one perhaps primarily psychological, but I think there's an interaction between the 2 clearly. So we know we're part of a learning network, and the topic of shortness of breath just came up at the last meeting, and people around the network were saying, what do they do for it, for patients with shortness of breath? And, we covered a lot of the things that Dr. Nambiar talked about, but there were also some centers that are trying some non-pharmacologic interventions. And a couple of them specifically asked about, they say, well, we tried to address underlying mood disorders, or we do mindfulness training, or we do breathing strategies and things like that. So I think that's how when we can think of this as holistically, as these symptoms are not just in isolation, when we don't have great evidence-based treatments, then we have to think kind of a little bit more broadly.
Yes. Dr. Tegaren, in another comment?
I don't. I know we're long on time, so maybe that's a good place to end this.
Okay.
Okay.
Yeah, definitely a lot to think, but I invite everyone to please stay tuned and join us in our next session. This is very interesting, and this is the essence of the ECHO, when it's an opportunity that we all teach or we learn, and we come here and join us in this space. We don't have anything else to add, but just to say a huge thanks for the case presentation and also for the didactics, Dr. Sabat, the lead specialist, and everyone that joined us today. And please, in the chat, you will see that during a continuing education credits and certificates of participation, please complete this presentation survey, and your feedback is so important. Other thing, as a homework to think, if you have a case to present, please reach out to us. We would like to hear from you and how you're managing your patients, or what are the challenges that we face up. Well, with that, I just would like to say thank you again, and please stay safe and enjoy the rest of the day. Thank you very much.
Thank you.